You're going to kick us off.
All right, everyone, welcome to today's session. We are really excited. 2024, new topic, new subjects. Welcome to our first session of 2024. Today, we are going to be talking about Intro to AI-enabled digital health services. It is the first session in our AI learning series. Thank you for joining us. I'm going to hand it over to Sylvia, who will be moderating today's session.
Great. Thank you, Aislinn. If you can advance the slides. We have a few housekeeping matters to address. Remember, you have muted upon entry. If you have any questions, please use the chat function. We will try to monitor if there's any question and answers posted. Dr. Abramoff, our presenter, will present the full 45 minutes and then we'll have questions. So let's go ahead, and the session will be recorded. So please keep that in mind. And then I'm going to hand it off very briefly to Aislinn to just make sure that we have all of our disclaimers in place before we do the introduction.
Yes, as you all know, today's session is only for informational purposes. CTRC does not provide any legal advice or have any relevant financial interest or affiliations with any products or services that may be mentioned in today's session. We are wonderfully funded by HRSA. Our grant number is posted below. Wonderfully brought to you by HRSA and some state funding to provide some education here today. That's it for the disclaimer.
Great. And I do also want to flag that we are also specifically funded by the California, the state of California Rural Office of Rural Health. So we're very appreciative of that funding as well. So we'd like to thank them. So with that, I'd like to introduce a really a global expert in healthcare AI, Dr. Michael Abramoff. I've known now for many years. Really had the great opportunity to meet him, I think back in 2016, when the then Obama administration was working on developing some foundational policies at the national level around AI. And there were very few physician voices and very few physicians really motivated to advance the discussion in an informed way with lots of subject matter expertise outside of the field of radiology. So Dr. Abramoff is quite unique. He is a fellowship-trained retinal specialist, a computer scientist, and an innovator. He is at the University of Iowa. He has a joint appointment because he's quite the overachiever. But I think really quite significant is what brought Dr. Abramoff to the attention of my then employer at the time, which was the American Medical Association, was that he was doing some groundbreaking work around autonomous AI systems, specifically in the context of detecting diabetic retinopathy, a condition that disparately impacts communities of color, and where access to specialty care is particularly challenging. So Dr. Abramoff had identified an area of tremendous need where the scalability of new digital modalities can be quite challenging. And this was an area where a new digital modality, an autonomous AI system that had gone through a very rigorous process, was being considered for the first time. And in many ways, Dr. Abramoff has been a trailblazer ever since. So not only has he gone through the FDA process, he also navigated a payment system, the Medicare system, and he is making headway in helping to architect an ethical framework that is evidence-based and really centers patient safety and addressing equity. He is widely cited and he has published extensively around the issues of healthcare AI. So I could go on and say a tremendous amount more, but I do want to flag, for instance, that he is part of the founding group that is an FDA initiative collaborative related to ophthalmology imaging. So with that, I'm going to hand it over to Dr. Abramoff and have him take it away for our inaugural session. Dr. Abramoff, you're on mute.
Typically happens. Thanks so much, Sylvia, for these nice words. I'm always, humbled by them. So, let me make sure that you can see my slides before saying anything else. Do you see it? Because I do not see my slides. Hold on. I know what's going on. It was working before. Hold on. Where is it?
So
Yeah,
while
see.
Dr. Abramoff is locating his
Okay.
slides,
Yeah, there we go.
oh, excellent.
You should be able to see my slides now. Can someone confirm that? All right. Well, I won't belabor the first slide because it essentially says what Sylvia already said. So we're saving a few seconds here. And as hopefully became clear from what Sylvia said, I have a lot of conflicts of interest. So I'm required to disclose these, and they're on this slide. Happy to talk more about them. So let's go into a brief history of AI. And I want to name some names because we're standing on the shoulders of giants, and that's always very important to realize. After that, we'll talk about the role of AI in healthcare. So we'll be more specific about healthcare, autonomous AI, and what it means, what it took to bring something to benefit patients in health equity, and what evidence we currently have about any of this. Because I'm going to say a lot of things, and you should always question, what is the proof for that? What is the evidence for that? And so hopefully I can convey that there is a lot of evidence, but happy to be criticized on that. So let's start. And then after about 40 minutes of this, there's room for questions. I saw some very exciting questions already, so we'll look forward to a refreshing discussion. And AI really started in the 30s and 40s with John von Neumann, where it was computation that was really being studied from a mathematical perspective. Then separately, people worked in artificial neurons, essentially modeling what we knew about the brain, even in the 30s and 40s, and how to mimic that with mathematical equations, not yet in computers. When that merged is around the 50s, where computation was strong enough to be able to model these artificial neurons, then the field really took a strong, acceleration, so to say. David Rumelhart comes to mind, Geoffrey Hinton. He's still active in AI world with artificial neural networks, multi-layer neural networks, and that's really what we will be talking about mostly. But meanwhile, there was something else, which was the information theory of the brain by Claude Shannon, also in the 30s, and everyone who uses a cell phone or any computer still uses the equations that Claude Shannon was able to develop. He's underestimated in terms of importance of what we are doing with AI. And I always look forward to working with. I continue to work with FDA, like Sylvia said, and part of that is bringing information theory into regulation of AI. And then finally, there's neurophysiology. As we learn more about mimicking the brain and neurons in computers, that also made us better understand how the brain works. So there was this sort of back and forth between the artificial neurology, so to say, and the real physical brains of animals and humans, learning more about how they function. And it ultimately led to better understanding how, for example, clinicians think about when they look at a patient. And that is, of course, relevant for what we are going to discuss. So AI in healthcare is nothing new. I mean, it didn't come up in a day, or I was definitely not the first. Even in the 60s, people were trying to already apply these thoughts about artificial intelligence and what we knew about the brain, especially at Stanford, into medicine, trying to, example, decide or help a doctor decide which antibiotics to prescribe for a certain diagnosis. This was very, for now, if you have an iPhone in your hands, very primitive, or ChatGPT. But really, the most important advance of people working on this was not so much the AI, but more that fact that you could type in the diagnosis for a patient or the symptoms of a patient. That was generating the most excitement, not so much that there was some thinking going on behind it. What antibiotic? This was really the first electronic health record that you've seen. Went away, nothing was very useful, deemed useful, never got, helped or even harmed, and we'll get to that. A single patient. In the 80s, as you can see from my hair color, I'm very, pretty old. And so I've actually been working in the 80s and early 90s on the second generation of AI in medicine. We tried again, but we were limited by the quality of the input data. Because if you listen as a doctor or anyone to a patient, you will essentially, the patient translates what they experience in terms of their disease into words that is noisy, right? There's a lot of loss. And then as a doctor, you listen to the patient, there's moral loss. It's like a telephone game, right? Where you probably know this game where you tell a story to one by one, and it's entirely lost by the 10th person. And this is the same. The more, middlemen or interfaces you have, the more corrupt the information becomes, and the harder it is to make an AI that performs really well. So that type of data is, we're getting better at it, but it was relatively better to use digital data. And that really happened in the 2010 when CMOS sensors from cell phone cameras and others became very affordable, and in radiology and in ophthalmology and dermatology, you started seeing low cost, relatively low cost images, and that's very objective data. There's no scanning, there's no interpretation of someone's words by a doctor and then translating that and typing it in. It's straight from the patient to the computer, and that really allowed us to have almost noise-free data, and that I think is allowing us to have these high performances where the accuracy of the AI is higher than the clinician like me. So that's why we are where we are. But healthcare is very special if you look at it from AI, from Silicon Valley, so to say, because a few things that are different. You've heard about ChatGPT and other LLMs, and their high quality is very wide. You can use Twitter or X, you can use the internet essentially to garner a lot of data. Well, that's not the case in healthcare. Healthcare data is scarce. Many times it uses radiation, so you can actually harm the patient by getting that data. Many diseases are very rare, making it very hard to get cases. And it may interest you that for developing AI, it's important to have cases without disease, to have examples of what an image, what information looks like when the patient has no disease, to be able to know how good you are from differentiating or diagnosing or treating a disease from no disease. And that's really hard because in healthcare, mostly you have patients and they get imaged, but not normals. And why harm them when it's not necessary? So these are some of the issues. Another issue is that, let's say that you're trying to develop a self-driving car and you want data for that. You have a car drive around with a camera. And if the car runs into something and hits a fence or whatever, that is, the truth. That happened, and you can use that to make your algorithm better. That is much harder in medicine, where, for example, in chronic disease, diabetes, hypertension, heart disease, it may take 10 years before an intervention, a diagnosis, will see to have an effect on maybe disability or death or blindness or myocardial infarct, etc. So it's much harder in many cases to get a truth, a high quality reference standard, we call it. And then also challenging in many cases is that you want the data to be as clean as possible, and that can be hard, especially if we're talking about underserved areas, minorities, rural communities, where there's not much, essentially, resources to get very expensive operators with high salaries to do your imaging. You will have to work with the staff that's already there, and they may not have experience in a very special imaging technique. So that's another constraint in healthcare that you need to deal with when you develop AI that is not in any other field. And so allow me to say this, because I think this is the central problem in healthcare, is productivity. And Sylvia and I have a lot of conversations about this since we early on met, but allow me, okay, a few seconds, and then we'll move on to what you're really interested in. But what productivity means, and I'm from Iowa, and as you can see in the bottom, you see these combines harvesting corn, right? And that used to be 100 years ago, almost manual labor, with maybe a few horses if the farmer had money. And so we can do so much more with this automation and mechanization in agriculture. And we haven't really seen that in healthcare. In many other fields, and that's the graph on the top right, you see this green line that's just measuring from 85, but it's the same 100 years ago, ever increasing productivity, ever more production of cars, planes, food, cell phones, whatever you want, with the same amount of labor. And that means that as a society, we get wealthier. Well, the yellow and red lines on the same graph are healthcare. And in healthcare, not only what some people suggest is that we are not becoming more productive, definitely I'm not seeing, for example, or treating more patients than I did 20, 30 years ago when I started. I'm old. And so I'm seeing what, maybe some recently graduated residents are not seeing. But you can see it's declining. It's actually, we're losing ground. And that is terrible for increase in prices, increase in access, increase in health equity. The more expensive it becomes, the harder it becomes to make it available for everyone, to make it ubiquitous, which is my and many other people's in this community, its goal. Healthcare has the potential to be ubiquitous, but right now we're definitely not moving in the right direction. And I think that AI and autonomous AI is a really good answer to solving this problem. And we actually have some evidence now. So just as an aside, I mentioned, IT and computation in general. The problem is, of course, that many attempts have been made to do something about productivity in healthcare. And one of the most recent ones is electronic health records, where there's many advantages because, few people can read my scribbles, right, as a doctor. So it's good that we're now forced to type this in, but it did mean a loss of productivity. So yet another example where rather than making things better, as far as productivity is concerned, IT made it work in healthcare. So I mentioned productivity. I also mentioned that I would not talk too much about it, but I do want to talk about all the other issues that we see in healthcare that, in my view, are derived from the lack of productivity, the loss of productivity. So first of all, top left is health inequity. And it's primarily, in my view, a problem of unequal access. Some people do not have access to doctors, too far, too expensive, they don't have the opportunity, long wait list, just no doctors available, no other providers available. That's a big source of unequal outcomes in healthcare. So that's one problem, in my view, we can address, and I'll show some evidence of that. An example that is more on the geographic level, but it's the same as for racial and ethnic minorities, is eye care for diabetes. And we'll talk a little bit more about it. So that's why I'm drawing it out. So on these two maps of the US, on the left in purple, you see more dark purple is where there's more eye care, more ophthalmologists per county. So that's mostly on the coast, including in California, but not in the rural areas. And then also the next map is in orange and red, where there is diabetes, which has a need for eye care at least every year. And you can see that's very much focused in the southeast, and not at all where eye care availability is concentrated. So this is just an easy visual representation of these disparities in access. And then, Sylvia actually gave me the figure on the bottom right. There's yet another problem, which is that within aging population, there's more demand for healthcare, but we're not keeping up in training enough providers and physicians and other nurses, etc. So that's another problem, all of which, in my view, and we're starting to prove that, can be addressed by AI. Here are some examples of the equity aspect, where we have now substantial proof that we can improve health equity and eliminate disparities, at least in the diabetic retinopathy space, and also that we can improve productivity. I'm really proud of the study on the bottom right. It was in Bangladesh, so a very low-income country. I've never been there. We are able to implement AI at scale and improve clinician specialist productivity by 40%, which is amazing for a country like that, where there's literally no resources to spend money on eye care. And now they can have so many more patients have appropriate care. I mentioned a few times autonomous AI, and then people ask me, well, what do you mean by that? And I think it's actually pretty specific. So assistive AI and augmented AI, and I should have mentioned augmented because that's not part of the CPT definitions, is where the medical decision is made by a clinician. That also means that the legal liability for that medical decision is with the clinician. So if something goes wrong with the patient, there's a medical malpractice, process or processes, and the liability will then rest by the one who made the decision. But it has one very important consequence, which is that the patient already is in the care workflow. So an assistive AI can help a doctor, a provider, but it means the patient is already there. And as we saw, health inequity in many cases is because of lack of access. The patient doesn't even go in. So you can build assistive AI as long as you want, as much as you want, but it doesn't really move the needle for these, what I call invisible populations, who don't even go. So it means that assistive AI can really help with outcome improvement for existing patients, better quality of care, maybe lower cost, hopefully, easier process for maybe the physicians, better job satisfaction for physicians and other providers, which is an important issue, as I'm sure Sylvia will agree with, and she went through that. Autonomous AI is different, because here the medical decision is made by the computer, and that of course has medical liability consequences, because now, and the AMA agrees with that, the AI creator has to assume liability. It cannot be that you, as a provider, as offering a service, you have a computer do it, and then if something goes wrong and it doesn't perform according to the standards and how it was promised, that you would be held liable and not who creates the AI. So that should be with the creator. And that was a really important step, I think, even for FDA. It means you can be at the point of care and immediate where the physician or the provider is not. I'm a retina specialist, but now you can get a high quality, in fact, higher quality diabetic eye exam everywhere where there's an outlet, right? Where I'm not, and I cannot be, in Bangladesh. But that also means it can be added wherever the patient is. And for example, for diabetes, it's really important to realize that the inequity is not from the people visiting their doctor for the diabetes management. They do go, 95% patients do go. The problem is they do not go for diabetic eye exam, and that's only 15% and less for minorities. And that shows that the real world value of autonomous AI has the potential, and is now proven, that you can improve the outcome for patients and populations as a whole, meaning address health inequity in a straightforward way. By the way, and people sometimes ask me about that, so what about ChatGPT and OpenAI and large language models? Well, everyone can now build an autonomous AI. The difficulty is not anymore technically, how do you do this? These are two sentences in blue, write, accept, Python script, etc. And that will generate a pretty well-performing AI from publicly available data. So the challenge is not in how to build AIs technically, it's how to implement them. How do we know it's safe? How do we generate trust? How do we embed them into workflow? And how do we use them to benefit health equity and patient outcomes? And not, glamour AI, where it's really cool to build it, but it doesn't have any clinical use. As you see here, I know Sylvia likes this. Stop glamour AI, so at request, I put it in. There's two approaches, and I sort of started to sketch that to develop healthcare AI. One is, I like, it's a square peg for a round hole. You're in a silo. I'm from Iowa. That's a grain silo, right, for corn. And in there, you see a sort of neural network. And what we're trying to convey is if you develop these AIs in silos and do not interact with the healthcare system in this case, you will be building a square peg for, you don't even know about the hole. You didn't look for the hole. And so that's glamour AI, right? Oh, we have these cool AIs. Let's find something in healthcare that we can address. You start with an algorithmic solution and then you look for a clinical problem. That's not, in my view, the way to do this. That I call glamour AI, where people get very excited and it doesn't have any clinical or equity benefit. On the other hand, if you start with the patient's problem and say, well, what is the process by which I can improve the best outcome, the best way of improving health equity? And what is these processes, and identify those? And in many cases, we know that. It's not like it's an unknown problem. You just need to look for it. And then let's look at which role, if any, AI can play in that process. And then build that. And then you have a lot of round pegs for round holes. So now to a little bit more specific about diabetes, because diabetes is a giant source of health inequity. I'm sure many of you, I'm not sure exactly who's in my audience, but I'm sure many of you are aware that diabetes is a giant problem in the state of California. 34 million people in the US have it. Almost 60,000 people a year go blind as a direct result of diabetes. Most important cause of blindness under the age of 75. And at least 44% of Medicaid managed care patients do not get an eye exam. It's probably more than that, but it's hard to measure that. The important thing is that the visual loss is almost entirely preventable if caught before there's any symptoms. So I treat these patients, and the problem is, in many cases, they come in when they have symptoms. It's much too late. There's permanent damage. I cannot prevent visual loss and blindness. If it's caught early, then we can still do so much, essentially prevent almost 100% of blindness. And that means that the diabetic eye exam is key, and that's why you hear every standard say, if you have a patient with diabetes, get them to get a diabetic eye exam every year. And that doesn't happen, like I said, less than 50% get these eye exams. It's a giant source of health inequity in terms of diabetes and getting care for diabetes, but even more importantly, the differences for different races and ethnicities and rural versus urban groups are even bigger in diabetic retinopathy, diabetic eye exams or screening. And so it's sort of a triple or quadruple, quadrifecta, I would call it, of vulnerabilities, right? Where they have worse outcomes for diabetes, less diabetic eye exams, worse outcomes for diabetic retinopathy, and just receive less care. So it's a giant source of health inequity. So what did we do? And now here comes my conflict of interest, because I happen to found a company that sort of tried to put into a AI that is regulated by FDA, it can be reversed by CMS, from these scientific prototypes. So I did a lot of science, and then if you do a lot of science, you think, it will be adopted. Well, it never does. And you actually need to make it into a venture, into a company. That's just the way healthcare works. And this is a fully autonomous AI. And the reason I'm discussing this is because it has so many examples of what we need to worry about, what we need to address, what the issues are when we try to implement AI into the clinical workflow. It diagnoses diabetic retinopathy and all forms of diabetic macular edema. It is proven to have no racial and ethnic bias. We'll get back to that, how important that was for FDA, because there's a lot of concern about it, and there have been AIs that have harmed patients. So we have to be sure that when we put these into clinical practice, that is not the case. It's more accurate than retina specialists, more accurate than someone like me. So the quality of care is essentially better. Again, I emphasize this because people, many times they talk about autonomous AI, and after 30 minutes, hearing me drone on, they say, well, and when does the doctor look at the patient? Well, the doctor doesn't look at the patient. The AI makes the medical decision. Very important to realize. And the medical liability is with the creator, already mentioned. It was designed and validated, and that was very important for FDA. We'll get back to that, in primary care. So it was not, oh, here's this AI, let's test it out, compare it to a bunch of highly qualified academic specialists who have access to a very specific patient population. No, it was done in primary care, low income areas, minorities, where we made sure that the entire system works with the existing staff, right? It's not like these clinics can afford to hire someone expensive, high salary, highly qualified to take these images and operate the AI. It needs to work with existing staff and existing workflow. So we made an AI that actually helps guide the operator through image taking. So literally, we used high school graduation as a criterion, and the FDA required us to get signatures from every operator that they had never operated a retina camera before. Diagnostics is, of course, in real time, and it maintains the integrity of the patient-centered medical home. So you need a prescription, and the result needs to go back to the provider taking care of the patient's diabetes so they can integrate it into the entire care and management of diabetes. So I already mentioned the silo. Here's another picture of a silo. It looks like where I'm from. And I think one thing we'll get back to again is that you can, let me see, I want to make sure I have the slide for this. Hold on. Yeah, I don't really have a slide for this. So you can do two things when you bring very new and maybe challenging technology into society. You can say, well, proactively, what do I expect the issues to be? And you see that here. Or I can introduce the technology and then wait for the problems to occur and then try to solve them, which is, make or break Silicon Valley approach, where you bring some technology like social media into society, and then 10 years later we realize, hey, there's a problem with children using this and there's actual harm being done. Well, how are we going to address that retroactively, not prospectively? So that's the difference. What we did here is consider the different issues that people can have, society can have with AI, especially autonomous AI. It sounds very scary because there's no human involved. Will it benefit me as a patient rather than harm me? Will it exacerbate rather than improve health disparities? What happens to my data? Is there racial or ethnic bias? Who's liable for errors and who pays for all of this? I sort of sketched already that, to think about it, but I want to make sure that you understand how crucial it was to address this proactively. And you can see bottom right, there's probably the most famous example of harm being done with an AI. where there was a racially biased AI being used by a payer, and it was designing care pathways for patients, and it harmed Black patients. It literally caused harm because it was inappropriately validated, developed, with a lot of issues. But there is evidence of harm by AI. This is not theory. This is real. And so we need to get it right, proactively. And so that's what this sort of slide sketches, and then I will go into detail. So it was a whole journey. On the left here, you see, hey, I've got this cool AI, and I think it can benefit patients, and that's why I developed it to fit into the workflow. And I wanted to, all the way on the right, to benefit patients and health equity, right? What do I need to do? Well, it took creation of foundation in ethics and ethical framework for AI, and that's very important. I will get back to that, which ultimately led to the FDA signing off on this, like Sylvia mentioned. The FDA approved this in 2018, first ever autonomous AI where there's no doctor involved. We talked about liability, medical liability. Very important, the issue of racial bias and other biases that we do not want in these AIs. When you're a doctor or provider, you may see 10,000 patients in your lifetime. So you can cause harm if you're biased to 10,000 patients. These AIs, like in Bangladesh, they can scale up to millions of patients. So the potential for benefit, but also harm, is much bigger. So we really need to think carefully about these bias issues. So I've been working on this with FDA, and we recently published a paper on AI bias and health equity, and I will briefly sketch that. Updating the standards of care, where everything requires a doctor to do the things that now a computer is doing, was not easy, but was necessary, because most providers depend on their standards of care to guide what they do with the patient. Quality measure was another important thing for value-based care, where things like quality measures for care gap closure, HIP, MIPS, and HEDIS, I'm sure you've heard about them or operate under them, they all were written in language that says a human needs to do this. Finally, reimbursement. In many cases, if you go to a health system, a provider, and say, hey, this cool new technology that will benefit health equity and will be better for your patients and more accurate, they will still ask, hey, what can I bill for it? And so reimbursement is key, and I will get back to that. But ultimately, what we started with was improving outcomes, health equity, productivity. That's my thing. And now we're starting to have randomized clinical trials that prove all of that. So that's really exciting. Last year, that was really exciting. But finally, with the real-world implementation of AI, we can prove all of these things rather than hope for them. So I mentioned proactively addressing all these concerns. Well, there's many people involved in healthcare, stakeholders. And, top right is many times when I explain all of this, I get, this guy again, right? And so there's patients. This is all about patients, right? So patients and organizations should be the first stakeholder, including the American Diabetes Association, populations and their organizations, civil rights organizations, etc., physicians and other providers, creators, bioethicists, regulators, value-based care authorities like PCORI and SQA, payers, investors. We look at this, and then Congress is very deep into this. So how do you address all these stakeholders? How can you get all of them on board with this pretty, scary sounding, hey, I have an autonomous AI, I want to make a diagnosis without a doctor, when we have for thousands of years depended on human doctors and providers to do things? Well, that required an ethical framework. And the more I think about it, the more proud of him. So this was an entire issue of the American Journal of Bioethics about our AI, ethical framework for AI. So there was one paper by me and my co-authors, and then I think 16 peer-reviewed papers in response to that with various criticism of the way we approached it. And essentially we said there's very important 4 bioethical principles. And now we're going to ethics. I have to do it. I cannot help myself. Non-maleficence or patient benefit, autonomy of the patient, justice or equity, and responsibility. So these are known across cultures, across ages, thousands of years old. You can find them all around the world. So it's very almost biological that we think about healthcare and about what is right and not in these terms. We do not always find the same balance, but we all think about each of these aspects. They're crucial. And so when you think about ethics and AI, what you see in many cases, at least in the tech companies, and I mentioned 2 names here, sort of an outside committee of ethical experts that then look and dictate at what that organization is doing in terms of its AI and go through it. And they essentially tell the engineers, hey, you be ethical. And if someone tells me to be ethical, I say, duh, of course, I'm ethical, right? That's not what we did with this ethical framework. With this ethical framework, I essentially said, well, we need to be able to measure it. How much do you meet each of these bioethical principles? 80%, 70%, 100%? Are we happy with that or not? So an engineer can measure for themselves how much what they're working on is meeting a certain or multiple ethical principles. So that's not someone from the outside saying, hey, you're ethical or not ethical, based on what? No, you don't need to say, duh. You say, well, I'm meeting this ethical criterion 78%. Go away. Or you're right, I need to meet 82%. Now we have something measurable. That, I think, was a crucial insight. Not new, but we sort of formulated for AI. And here's how it works in practice. So you have these bioethical principles. Here's patient benefit, or first do no harm. That's probably something you've heard for doctors. Here's health, equity, or justice, right? Seeing people as a group and making sure there's no inequities between groups, and autonomy of the patient. And so the bold statement I'm trying to make is that every AI, every provider, every health system has to find a balance between each of these three and responsibility. And it can never be perfect. A good example is smoking cessation. If you tell patients not to smoke anymore and keep repeating that affects their autonomy. They're not fully making the decision themselves, but it does improve their outcome for lung cancer. It's a very simple example. You can see that as you want more patient benefit, you lessen their autonomy in many cases. The same for health equity. You will have to find a balance. Some people care more about the health equity, so then it will move to the right. Some will more about patient benefit. And so you need to find a balance, and everyone and every organization will do that slightly differently. But the ethical framework doesn't tell you exactly where you need to be, but it does allow you to analyze it in these terms and have a basis for discussion and making decisions. So that's what the ethical framework does. It does not tell you, hey, you need to be 80% sensitive or 90% accurate. Not at all. It just allows you to measure it in a way that's transparent. And again, here you see it again, how we measure these different bioethical principles. You have a metric for it, and then you find a balance, and that is for the AI creator to do, and then for the FDA to look at, for CMS to look at, for Congress to look at, for patient organizations to look at, for bioethicists to look at. But now we have a basis for evaluating and discussing that, rather than you're not ethical, I'm ethical. There's not much discussion there. And so what is interesting is that this ethical framework is now being used in a lot of different ways. FDA is using it as what they call, or like to call, the foundational considerations for AI, and I helped to lead that work group, and that work is ongoing. That's on the left. On the right, you see the paper recently with FDA on considerations for addressing bias in AI and how it affects health equity, and we'll get into that a little bit, time permitting, because I have like 8 minutes left. And then even reimbursement we put into an ethical framework. So how do you decide the charge or the reimbursement for AI, where everything in reimbursement and payers has always been based off doctors and nurses and everyone else doing stuff for a certain time with a certain expertise, right? RVUs, etc. And now suddenly you have an AI. And how do you value that? That was tricky, but we did this framework, and I'm very proud that Sylvia was willing to be a co-author on this very exciting paper. And so I went through this. I don't think we have time for that. So this is, I think, one that I want to pull out. Like I said, Sylvia was a co-author, many from FDA, but also important. Remember that a paper in Science about the AI that caused harm to Black patients. That was done by Ziad Obermeyer, and I'm very proud that he was part of this work group and this serious discussion. So what it does, for some reason the check marks got lost. I'm so sorry. But anyway, what essentially we said is, many times people talk about AI bias in terms of training sets. So if you know a little bit about AI, you may have heard about this. A lot has to do with data for training the AI to make it, start and better and better and better. And if the data you use is biased in some way, then you can easily build in bias into the AI without noticing. And because the goal of AI when you want to improve all these things, is to scale and use it on millions of patients. And so if you're not careful, you will introduce bias and affect the outcomes for millions of patients in a desirable way if you do not analyze this the right way. So what we did was say, well, yeah, there's AI bias in the data, but there's so many other instances where you can introduce bias. And we went through all of them. From the concept of, hey, I have a healthcare process, I want to build an AI. What disease, what level of disease, which patient groups, what is, as an example, the imager or the equipment that I need to get the data for the AI, to design, development, validation, access, and monitoring when it's in the field. Everywhere you can introduce bias, you need to measure it, you need to mitigate it. Let me get back to that concept. You can conceptualize an AI and say, well, I'm going to use it with this very expensive imager, camera, MRI. And if you're not careful, it's relatively easier to build a high-quality AI, high-performing AI, if you have really good input data. And so now biased where the patient groups and the populations and the provider groups and the health systems who can afford this MRI will bias who even gets access to this AI. So it's relatively easier to develop the AI because the quality of the data is better, but you build in a bias. And so if you use a lower cost imager, the job for the developers and the design, etc., is tougher because it's hard to get the AI to perform well, but it allows you to be in spaces that otherwise you would not, because now they can afford it. So you can see how from the concept you can create bias in your AI, and you need to measure that and you need to analyze that and decide what to do. You can never exclude bias fully, but you have to mitigate it and measure it at all of these stages. I can give examples for every stage, but we don't have the time for them. But hopefully I get across that AI bias is a more complicated thing than just a bias in the training set. And that, of course, major implications for health equity, which we can mostly measure when it's being implemented. I think I'm running out of time, Sylvia. What do you think? A few more minutes?
Yes, absolutely.
Okay. So also pretty, I see that Sylvia is also in this paper. I always do my paper. I love doing papers with Sylvia. So here what we did is slightly different. Let me see, yeah. How do you pay for AI, right? How do you create reimbursement? How do you, as an AI creator, as a developer, set a charge? Let me take you through this. You can say, well, if I do 1 million patients and I've done the R&D and the validation and everything, all those costs are amortized, then doing one more patient is mostly the cost of electricity, which is very low. It's like a cent. That is not going to be, I can tell you, and we can discuss that, a viable business model for any company. It's not going to work. It will not scale. You can base it on the total cost of ownership. That means that you look at all the costs and then say, well, you need to pay what I split it up over, let's say the health systems that want this, but now only it's very expensive, and large health systems, large HCOs can get it where small practices cannot. And that's not what we want either, especially if we want to serve underserved communities. You can look at the cost effectiveness. The problem with that is often that if something is really cost effective, it means that it is cost effective at a higher level than we're currently paying providers. That's the whole essence. What cost effective analysis does is put the cost of the provider currently doing that into the equation, and then say, well, the cost of doing this and paying these providers saves me money comparing to let these people go blind or die or get very disabled. And so essentially, use that cost, you would drive up costs rather than drive down. The point in this is always drive down costs for the healthcare system and not drive up costs by charging more than the doctor. So it needs to charge less. So the cost effective is not a good analytical tool either. You can say the substitution color would just pay what we currently pay doctors. You're still not saving money. You're still not moving the needle, all these things. So what we chose, what we called, somewhat boldly, equity maximizing value. We said, well, what is the willingness to pay? Currently, as a society, clearly willing to pay for 20% of the people who need it, mostly not the underserved people, to get this item. How do we set a chart so that we can, for no more expenses, do it for 100%? And that's what we came up with. And so with this analysis, we went into Congress, we went into CMS, we we talked everywhere, all the stakeholders, don't forget, and all the stakeholders supported this equity measure of value. And it's interesting, I went into CMS saying, here's why it needs to be $55. And people said, no, you need to ask for 85 because 55. And we said, no, here's why it needs to be 55. And it became 55 a few years later, because kind of Mrs. Smith goes to Washington, really cool. And so the implementation is really important, because if you don't get all stakeholders on board, let's say physician organizations, AMA, CPT, by the RUC, or TMS, or Congress, or anyone else, it will not happen. You will not get reimbursement. And I hope I have this. Oh, sorry. I forgot to put this slide in. So there was a company, Pear Therapeutics. It had a very high performing AI for addiction. Randomized clinical trials showed it worked. It's really benefited patients. FDA approved it, and they couldn't get reimbursement done, and it went bankrupt last year. So all this high quality technology that could benefit so many patients is gone forever, not because it didn't work, not because they couldn't get to FDA, but because they didn't get support for reimbursement. And it shows you how important it is that the regulatory, but also the reimbursement aspect, be addressed, because if you don't do that, it dies. And that means stakeholder support. So we did that. We got all these, kudos. Really proud of what CMS did, where they spent 30 pages discussing this first ever reimbursement for an autonomous AI. What were the guardrails? What about bias? What about safety? What about health equity? Everything was being discussed and back and forth whether we should do this, and ultimately we did for a very narrow autonomous AI for the diabetic eye exam. It was amazing how fast it went, really looking back. I won't go over this. What is really important for last year, because I've always been presenting material like this, but always saying, where does the potential that, and hopefully that, and it may, always be careful, forward-looking words. But now we started to have proof. Here's some publications which show that health equity improves. In fact, we did a randomized clinical trial in the Baltimore area among Black and white patients, randomizing to AI and no AI, and health disparities disappeared in the Black population. It was gone. There was no health disparity anymore. And that paper, here's an abstract, but the paper was accepted by Nature and is coming out in the next few weeks. We have to find the proof. So coming out, very exciting, randomized clinical trial, proof. Similarly, productivity, we were able to show in a randomized clinical trial, AI, non-AI patients went through either, were randomized, that productivity of the clinicians improved by more than 40%. That is more than the productivity increases that we have seen in all of industry over the last 50 years. So it's a giant step, or it can be a giant step. And this was in Bangladesh, in a country I've never been. We implemented at scale remotely. So this is really highly scalable technology. And more importantly, it's real world. Many times you will see prototypes of AI being tested in these type of environments, and then people say, well, it did this or did that. Not randomized clinical trials, this is the first, but at least there's some evidence. But there's a big difference between a prototype and going through this entire process of FDA, product market fit, meeting CMS, meeting standards of care, etc. It changes what it does, how the output looks, how it interacts with the clinicians. And it's only worthwhile, in my view, to test that fully ready, real world thing rather than a prototype where it will change because of regulatory constraints. This is back to the training set. Too much material. I will stop here because I'm really looking forward to the discussion. Let me stop my share. Hold on.
So
okay.
First of all, thank you. I mean, you are a tour de force and really covered the gamut. And I really want to thank you for agreeing to be the inaugural speaker here. We do have several questions, but I want to underscore a couple things. And this is like rapid fire before we go into some of the audience questions that we had submitted early on. I want to make sure that folks hear the answers to this, because it's what clinicians and patients need to know when their provider is using an AI system. So the first is IDXDR or any autonomous AI system, and this is different than non-autonomous AI systems. But an autonomous AI system, what is your view? And you mentioned it earlier, but I want to underscore it, around liability. Is it the provider that has not developed it, or who is responsible for an autonomous AI system that malfunctions, that does not work properly? Where should that liability lie?
With the developer, the company in this case. And the reason is, if you're a provider that's essentially outsourcing this diabetic eye exam, not by referring, by doing it in your clinic with your patient, the whole point is that you are not comfortable doing this yourself. And it would be crazy for you to now assume liability for something that you do not feel comfortable doing. That is wrong. The developer knows how it should be formed. The FDA has agreed that you make certain claims about performance. If it goes below that standard, that's a liability issue. It's not, it will miss cases. The sensitivity and the accuracy is not 100%. Just like with a doctor, mistakes will be made, but that's not what is at stake here. It's if the performance is below what the FDA and you agree as a developer agreed on, which is why you as a provider are adopting this AI, because you hear those claims and you say, hey, the FDA signed off on it, I trust that. Then if it is below that, that's a liability for the creator.
Right. And I just want to underscore that, because in the course of my work previously, this was not the majority position of a lot of large companies and innovators out there. And from a clinician perspective, if you're going to adopt a tool, you want to know where that liability is going to lie. The second question, before we dive into the questions from our audience, is around equity. So when you were innovating and developing your tools, and you were going to the FDA for approval, again, we have a lot of our audience who are from federally qualified health centers, rural health clinics, other underserved areas. When they're looking at tools, what should they be asking about the equity, and how did you evaluate equity and discuss equity when you were going to the FDA? Because this is a tool that could have high impact, as you've since demonstrated, to really address disparities, health disparities in underserved communities. But I'm a clinician, I need to ask, where's the liability and how do I assess equity? How did you show that this was a tool that addressed that concern or bias?
Yeah, so I want to separate the bias, which is underperformance in some groups, vulnerable groups, for example, right? And which is measurable with that diagram I showed across the different phases. And there's health equity, which should be, if you conceptualize it to improve health equity, if that's your claim, then in many cases it needs to improve access. And you can measure that in various ways. One is diagnosability. It's relatively easy to make an AI, like I said in the beginning, that works really well on a small group of people. But to be able to apply it to the entire population, you need to prove that. You need to prove that it works in older people, people who are, maybe less mobile and in wheelchair, who have more, maybe in this case, cataracts, who are not used to being in a clinic. Many, many factors, who may not have the money or the resources to pay for this, or have insurance even. And so it needs to be affordable, which has consequences, like I mentioned, for the equipment. If the equipment is very expensive, there's no way it's going to work for an FQHC. They will never be able to afford it. So it needs to work in an environment with the existing staff, because at least part of the equation is the salary, right? You can say, well, this is really low-cost equipment, but if it still needs, a PhD to operate, an FQHC is not going to hire an extra PhD just to do this exam or multiple exams. It needs to work with the existing staff. Can you prove that? And so we worked out with FDA that in the trial, we used it in those clinics that we identified as being in underserved communities. But not only that, it worked with the existing staff. And like I said, high school graduation had to be the only requirement. I cannot help you if it's below high school graduation, but that is the least.
So we do have 3 questions, but we're almost at time, so you have to answer them very quickly. So the first is any thoughts or recommendations concerning the use of AI in diagnostics related to the issues faced by Babylon Health?
Yeah, Babylon Health is not a Theranos, right? So they had AI that was not regulated. I want to differentiate high quality AI that's FDA regulated from all all AI that's being developed by various groups and not ever monitored. And so I can't say much more about Babylon, but it's a really example of how this can sound if you don't know what you're doing.
Right. So the importance of regulators in this space in the application of healthcare is essential. And the next one is from a practice who and an expert who's run multiple ACOs, and one of their biggest spend areas, especially in rural settings, is ophthalmology. Specifically, the recommendation and use of eye injectable drugs for diabetics that may or frankly may not have wet AMD and other similar issues. Will AI help to prevent overutilization and billing?
Yeah, it absolutely can. I don't have scientific proof of that, but here's why. It's more accurate than me. It's both better at finding cases, meaning people with disease, but it's also better at finding cases without disease, without the diabetic retinopathy, and they shouldn't be treated. And so if it's more accurate for finding the people who do not have the disease, you can just, we should not be treating those. So there's potential there. It hasn't been proven, but absolutely it should help with that. In diabetic retinopathy, right? Not in other diseases. Right?
Yeah. So I'm going to ask Aislinn to bring up our concluding set of slides. And I want to thank Dr. Abramoff for, again, just a tremendous overview, which is essentially the equivalent of, I don't know, 3 decades, 4 or 5 decades
Too much
of knowledge and expertise. So we will be seeing him again. This is not going to be his final foray with CTRC. He's one of our advisors, and we're looking forward to hearing from him again in the future. But with that, I'd like to flag that we are going to be having another webinar on regulatory and payment environments from 2 lawyers. So we've heard from a physician. We'll be hearing from David Vidal from Mayo and Sybil Rohrenbeck with a law firm in Washington, D.C. to talk about what is happening on the federal level. We will also have someone coming to talk about what is happening in California in a next webinar. That's next Tuesday, January 16th at 1 p.m. Pacific time. Also want to flag on the next slide that we do have an in-person workshop that we will be doing at the near the end of this month. Encourage you all to check out our website. It will be in Sacramento, and we look forward to seeing you in person to either establish a new digital health set of offerings in your practice or optimize your existing ones. So it's free and it's in person, and we'll be in Fresno and Los Angeles later this year. So with that, I want to bring this to a close with our final slide and thank all of you for participating, and we look forward with you joining us on this voyage. And again, thank you again, Dr. Abramoff. Be well.
Thanks so much. Bye-bye.